Good morning, all my friends over here in India, and good evening to friends in the United States of America. And welcome back to this weekly webinar that we have been conducting for the last 81 weeks, in the sense that this is actually as an anniversary. Exactly on this day last year, we have started our weekly webinars. In between, we had daily webinars also to the extent of about 30. And now this is the 81st episode, and I'm very glad that this is continuing. And the main reason for this continuation is Dr. Ram Tairam, Dr. Sridhar Chilumari, who have been like pillars for this particular program. And I'm sure that a lot more are getting benefited of the contemporary issues that we are discussing every time. So we have thought that now in between we had a slack season with COVID. So we thought we will do with long COVID and different system-wise discussion of the COVID problems post-COVID. So we have started in that way. And now I understand that there are a lot more cases that are coming up in the United States, and we expect the same thing to happen here as well. So, keeping that in mind, we will have a balance of both. So, the management of acute COVID and the challenges that we face day in and day out, and at the same time, people who have recovered long back but still have suffering from numerous ailments. So, we have to balance both these. So when we are going system wise, I thought that as we have finished with the cardiology early on, and we thought that we'll have the GI this time. And I'm very glad Dr. Jasbir Makkad has agreed to come on board and discuss both about the acute issues related to the GI in relation to the acute COVID as well as long COVID. So I would request Dr. Sridhar Chilumari to take over and introduce Dr. Jasbir Makkar to the crowd. And this is it's almost 100 people on board. And let's get
Yeah,
going. Sridhar, over to you.
yeah, thank you. And it's a great pleasure to introduce you, one of my colleagues and my former resident and fellow. So, Dr. Jasbir Makkar did his medical school from India in Maulana Azad Medical School. After he finished there, he did a fellowship in the residency in medicine at the University College of Medical Sciences in New Delhi. Later, he came to the United States and did a training in internal medicine at Bronx Albert Einstein, and also a fellowship in hepatology and gastroenterology. Although still early in his academic career, Jasbir has been outstanding in developing a big research portfolio already. He has a particular interest in non-alcoholic liver disease and fatty liver disease, and has published some important papers there. But his interests are quite varied in covering many aspects of gastroenterology, including delivery of care. More recently, we've been asking him to see most of the post-COVID GI cases, which have become quite challenging. And also, it's a time now. I think we covered GI a few months ago, but a lot more information is available as we understand the disease better. We're also taking a slightly different turn this time. Rather than just stick to basics, we asked him to cover other aspects of the management, including the importance of nutrition and are there any controversies in nutritional supplements and things of that nature. So I've asked him to cover all of that. So Jasbir, go ahead and start.
Okay, thank you, Dr. Shimri. Thank you for the kind words. And also, have a good morning, everyone, to all my colleagues in India. And without wasting time, I'll get started here. So I'll be presenting about the gastrointestinal manifestations of COVID, and later on, we'll talk about post-COVID and nutritional status. So the first and foremost, I'll compare with the three pandemics we had so far. On the extreme left, you will see here this current pandemic caused by SARS coronavirus 2, and in the middle you see SARS pandemic, which happened in 2002, and the extreme right you will see the Middle Eastern Respiratory Syndrome coronavirus. So all of them, if you see, there's one thing which is very striking different is the case fatality rate. The current pandemic, we see the case fatality rate is about 2.15 as compared to the other pandemic where the case fatality was much higher, 9.6 and 34.4. But if you consider the number of people who have been positive tested with this in the current pandemic, the number of people who succumb to the disease is huge. So 2.15 is a huge number in this context that more than 200 million are already affected. Now, incubation period for all of them is usually same, about 2 to 14 days, and they all have predilection to the gastrointestinal tract, and that's why they all have nausea, vomiting, and diarrhea. Though you see nausea, vomiting, and diarrhea less in the SARS coronavirus 2, the COVID-19 disease, as compared to the other two viruses. But it's not surprising to see that they all get secreted in the GI tract, and that's why the fecal samples are generally positive in a lot of patients in these diseases. Now, initially when the COVID started in China, it was not recognized that the diarrhea is one of the main symptoms. And even in United States, the CDC did not recognize diarrhea as one of the initial symptom to be screened in patients with COVID-19. It was not until this paper came in NEJM where they reported the first case of COVID-19 in the United States, where they reported the diarrhea. And as you can see in the diagram below, that the diarrhea usually starts around within the first week of the illness and usually lasts about 3 to 7 or 10 days and is self-limiting and resolves as the other symptoms resolve. But it may be different in other cases, which we will talk about in the subsequent slides. Now, the most common gastrointestinal symptom which we all have been seeing is diarrhea, nausea, vomiting, anorexia, loss of taste or altered taste, and abdominal pain. There are other symptoms like acid reflux, upper GI bleeding, lower GI bleeding, and constipation, as well as melena, which we have noticed in some patients. Now, diarrhea, if you take diarrhea apart from the symptoms of loss of appetite and dysgeusia, the diarrhea is the most common symptom of GI tract, which is caused by COVID-19 disease. And there was a meta-analysis conducted by American Gastroenterology Association where they had close to 11,000 patients. And what they noticed that if you consider only the studies conducted in China, the prevalence was about 5.8%. Whereas if you take the studies only outside China, the prevalence was much higher, about 18.3%. So overall prevalence worldwide, if you include all the studies, was 7.7%. Now, some of you may think that the COVID-19 patients having diarrhea, that may be the effect of the medication, but it's important to note that this meta-analysis brought this number that 8.6% of the patients had diarrhea on admission before receiving any treatment for COVID. So it's not just the medication which can cause the diarrhea. There are other reasons which can lead to the diarrhea in COVID-19 patients. Now, also, diarrhea may be the initial presenting symptom without having any cough or respiratory illness. So there are studies done by Ali et al. And Wong et al. And you can see that they noted that patients were having just diarrhea as the initial symptom. And more interestingly, later on the studies came where they presented diarrhea was the only symptom of COVID-19 without having any upper respiratory symptom whatsoever, any part of the disease, they just had GI tract involvement. So that is very much possible with COVID-19. And we have to be mindful of screening for this symptom when we are screening the patients for COVID-19. Nausea, vomiting, and abdominal pain are the other common symptoms after diarrhea, and they also have a similar pattern in the pooled prevalence in the AGA meta-analysis, where they noticed if you consider the studies only in China, the prevalence was 5.2%, which is much lower if you consider the studies done outside China, where the percentage was like about 14.9%, and overall prevalence becomes 7.8. And similar pattern with the abdominal pain. Studies in China reported lower prevalence 2.7, 6.6 in studies outside China, and overall 3.6%. Now, the mechanism of diarrhea so far is largely unknown, but there are different hypotheses put forward by the researchers. And the first and foremost is the gut dysbiosis. And that's because the COVID-19 is known to affect the GI tract, and the bacteria, the gut microbiome is affected. So that may be one of the factor leading to the diarrhea. Second is osmotic diarrhea due to malabsorption. And third, they have put forward is inflammation, which may be caused by the damage of enterocyte by the virus itself or the toxins by the virus. And this is also supported by the fact that some studies have reported very high calprotectin levels in patients who have diarrhea with COVID-19. But on the other hand, there are studies where they have done the histological examination of the biopsies of these patients who suffer from diarrhea, and the damage of the mucosa was not significant enough to say that there is significant inflammation. So this is contradictory. We still do not understand this disease very well, what exactly is causing the diarrhea. Now, there are also cases where they notice, despite having a large volume diarrhea in a patient with COVID-19, there was not even a single particle of virus detected in their stool. So there has to be some other factor other than just the virus directly infecting and damaging the mucosa of the intestine. There has to be some other factor. So then there was interest that it may be the activation of enteric nervous system by the virus, which ultimately leads to the increased secretion of intestinal fluids and the electrolyte secretion. So these are the common reasons we believe might be causing the diarrhea, or maybe a combination of few of these factors. Now, fecal oral transmission has been looked at by several studies. Initial studies were, as you can see in this table, they're mostly done in China and then later on from the other parts of the world. And the varying percentage of patients, depending on the time in the pandemic when the study was done and which region of the world the study was done, there's a varying percentage of people who test positive in their stool for COVID-19. And interestingly, if you see on the right side, the rightmost column, the patients even test positive even when the respiratory samples are negative, or the respiratory symptoms have completely resolved and there is just diarrhea and the stool samples are positive. And I'll come to subsequent slides why this is important to know, that the stool samples are positive even after respiratory samples being negative, because that explains some of the hypotheses how this virus is getting into the GI tract. We'll talk more in the subsequent slides. Now, the fecal shedding, there were two very large systematic review and meta-analysis done. Both came in 2020. The first one mentioned here was done by Cheng et al. In July 2020. They had patients and they noticed that 48% of them tested positive in their stool samples. And this number of 48% goes higher to 70% when you consider patients who have recovered from their respiratory illness. So if you take the sample after you have recovered from respiratory illness and then you check the stool sample, the 70% of the stool samples are positive for COVID-19. Similar results were there in the meta-analysis, which involved 95 studies and came out in August 2020. And it showed that 43% of patients tested positive in the stool for COVID-19. They noticed that the mean duration of the days when the fecal samples were positive was about 12.5 days, and the maximum days in their meta-analysis was 33 days. Although I'm aware of some case report where they reported that the COVID-19 was detected even after 70 days of symptom onset. So it is possible that late the virus can exist in the stool. And the meta-analysis also found that 35% of the patients had viable virus. Now, don't get confused by this word viable virus, because viable virus does not mean that is an infective virus, as was beautifully demonstrated by a study done in Germany by Wolf et al. And they found that a patient's having high viral load with COVID-19, and they isolated the virus, but that virus is not infectious. So just having a virus, even live detected from the stool sample, does not mean that it's infectious. So it does not mean that it's going to be transmitted fecal-orally and the disease can go on further like that. So we don't know. On the other hand, there are studies where they have found the viral protein and RNA detected in the biopsies, intestinal biopsies, several months after the patients have recovered from their illness. So and overall, the studies have not answered this question. The fecal oral transmission still remains unsettled. We do not know for sure whether the fecal oral transmission is possible definitely with this virus or not. Now, if the fecal oral transmission is not possible, then how do you explain this virus present in the stool? There are two theories here. The first set is that the researchers believe that the virus may be coming from the respiratory secretions, which a patient may be swallowing and going down to the stool. Now, there is a problem with this hypothesis, which I'm going to talk further, but what are the theories? How do you support this hypothesis that the virus can actually, this virus, which is not an enveloped virus, and we know that envelope viruses usually do not survive the gastric acid. So how do you say that the virus which is not enveloped and generally do not survive the gastric juices, how can they reach the intestine surviving this gastric juice? So the theories are that during the disease, when you have a pneumonia, respiratory illness, the secretions are so thick that the virus gets this nice coating of mucus, and that protects the virus against the gastric juice. So that's one of the possibility. And the second possibility is, yes, acid we know can destroy the virus, but acid, the pH is different in the fasting state as compared to the fed state. The fasting state pH is 1.6, which may be detrimental to the virus, but we don't know the pH of 5 is actually detrimental or not. So this is still up in air. We do not know whether the swallowing of this virus, the swallowing of the virus containing secretions, respiratory secretions leads to this, or there is something else which is causing this virus being present in the stool. There is also evidence that it's not just the virus being swallowed in the respiratory secretion. There is evidence in studies that the COVID-19 actually replicates in GI tract. And that is evidenced by the cases where you will see almost like 10 million copies per gram of stool, and you don't have enough viral load in the pharyngeal specimen. So if you don't have that much of virus in the respiratory secretions, it's impossible to have such a high viral load in the stool sample. So definitely this virus is replicating in the GI tract, and it cannot be just explained by swallowing the respiratory secretions. Second is the theory about the subgenomic messenger RNA. So when this virus replicates, during the replication process, it creates something called as genomic messenger RNAs as well as subgenomic messenger RNA. Eventually, when the virion particle is formed, the genomic messenger RNA go into the virus particle, but the subgenomic messenger RNAs are left behind. And when the intestinal cells are shed, these subgenomic RNAs can be messenger RNAs are detected in the stool. So if you see a subgenomic messenger RNA present in a stool sample, that means it came from a cell which had active replication of the virus. So this has been shown in the COVID-19 affected patients. Also, the subgenomic messenger RNA have been detected in cases even before the respiratory symptoms developed and long after the respiratory symptoms have subsided. So it is not possible just to explain that if you swallow the respiratory secretions and that will cause the excretion of this virus. So there is definitely more to it. Now, there are several studies where they have looked at the COVID-19 disease severity in patients with and without GI symptoms. And as expected, the studies, there are a lot of studies in different parts of the world, and the studies have conflicting results. On one part, we have the studies, a big meta-analysis involving more than 3,000 patients, and there was no difference in the disease severity of COVID-19, whether you have GI symptom or you do not have GI symptom, there was no difference. On the other hand, we have studies, there was the studies mostly from New York and the other one from Italy. They showed if you have a GI symptom, you have a better survival. The mortality was much lower in these patients. But when you go to other studies now, they show exactly opposite results. They showed if you have GI symptoms present, then you have a much severe course. There is a much more higher requirement of ventilator and higher mortality in these patients who had GI symptoms. Now I'll shift gears here and talk about COVID-19 and the liver involvement. Now, liver involvement is possible because ACE2 expression, as you know, ACE2 is the receptor where the spike protein of COVID-19 binds, and that's how it gets internalized into the cells. So ACE2 receptors are expressed in the hepatobiliary cells, and they are expressed in high numbers in cholangiocytes as compared to the hepatocytes. And this is very interesting because if you I'm sure when you see your patient, the most typical pattern of the liver function derangement in these patients is actually elevated transaminases and not alkaline phosphatase or bilirubin, which is very surprising because the expression of ACE2 receptor is much higher in cholangiocytes as compared to the hepatocytes. But it is possible, researchers believe it is possible that cholangiocyte may be just the reservoir, and having low receptor expression in the hepatocyte does not mean that the virus load will be less, because the other factors like the transmembrane proteins which we require for the internalization of these proteins may be expressed in higher number, which may not be expressed in higher number in cholangiocytes. So just having ACE2 expression in lower number does not mean that you will have the low effect at that part of the liver. Now, there are several studies, and these are not just the studies which I'm showing here on the table. These are actually meta-analysis. That many studies have been done. So there are like at least 7 meta-analysis I could find in the literature. And all of them show that the derangement of liver enzyme is very much possible with COVID-19. There are varying numbers. The elevation of AST was about 15 to 25%, and ALT was about 15 to 20%. Bilirubin was about 13%, like 7 to 13%, and INR was about 10%. Albumin was low, about a 50% patient, but that reflects the severity of the disease, and it is and the low albumin is also associated with the severe outcomes in patients with COVID-19 disease. And as you see here again, the alkaline phosphatase elevation, which was studied by only 2 studies, was present only in 4 and 6% of patients. So alkaline phosphatase elevation is not that common as compared to ALT and AST. So the summary of all these changes in the LFT from COVID-19 disease tells us that the transaminase alteration is much more common, and mostly the transaminase alteration is very mild. It's also important to know that the transaminase alteration is usually AST predominant, the pattern which we usually see in the patient with alcohol liver disease or cirrhosis. Now, this is possible that the COVID-19 may be affecting the mitochondrial dysfunction, or maybe causing the hepatic steatosis, or maybe the thrombi, which we know happens with COVID-19 and ultimately causes ischemia in the liver. And ischemia is known to cause more AST than ALT elevation. Now, we also know that the hypoalbuminemia, which is a non-specific marker, has been reported and it's been shown to associate with severe outcomes in COVID-19 disease. Now, the severe liver injury, elevation in serum bilirubin level, or the liver synthetic dysfunction, they're all rare in COVID-19. And usually you just see a little bit of transaminase elevation, which usually gets better spontaneously after a couple of weeks when the patient recovers from the illness. But in the severe acute liver injury, they have shown the liver injury to be associated with the very high inflammatory markers, interleukin-6 and ferritin. Now, there are studies where they try to prognosticate the elevated liver enzyme with the bad outcomes of COVID-19, but I think there is a bias in these studies because they tend to say that the patients who are admitted and have bad outcomes, who are having shock or requiring ventilator support, or who are in ICU, they have more dysfunction of liver. But you have to see the patients who are at home or are in the general wards, they might not be getting that many labs drawn. People at home are not getting any lab drawn. So there is a selection bias here. So we cannot really say that having liver enzyme elevation really means that you're going to have a bad outcome with the COVID-19. Now, what's the mechanism, how you explain the liver injury with the COVID-19? There are several mechanisms possible. The first and foremost is a systemic inflammatory response syndrome with this virus. The cytokine surge is there. Ischemia is possible with the thrombi, sepsis, and the drugs which we use as a supportive care or the direct treatment of the COVID-19, the treatment drugs which are available at the current time. Also, there was the study where they've shown that in the biopsy specimen in the postmortem COVID-19 patients, they found the lobular as well as portal inflammation in this COVID-19 disease, which explains that this virus might be actually causing a direct damage to the hepatocytes. Now, it's possible that the gastrointestinal and the liver manifestations in the COVID-19 patients are possible just from their medication which we have used. And I'll just mention a few medications which were used mainly in the initial part of the pandemic. Chloroquine and hydroxychloroquine, we all know, very commonly used in India. They're known to cause the GI symptom, nausea, vomiting, abdominal pain, and diarrhea. But they are not known to cause liver problems. So you cannot associate chloroquine so easily with the liver abnormality because that's not common with chloroquine. Then remdesivir was known to cause liver derangement, but I think this should not be any problem. This is not clinically relevant because after the Solidarity trial, which showed that remdesivir is not really useful in hospitalized patients, there is no mortality benefit, so it's not used that often now. The lopinavir and ritonavir combination causes both. It causes the GI symptoms as well as derangement of the liver enzymes. And then the drug favipiravir, which was initially used to treat influenza in Japan, and we started using off-label for COVID-19 as well. And they found that the patients were having GI symptoms like nausea or use of antacid or flatulence or diarrhea with this drug. Also, they noticed that besides GI symptom, they were having elevation of ALT and AST when this drug was used. So there is some association between this medication and GI symptoms as well as liver enzyme elevation. Now, coming to the topic whether having any pre-existing liver disease, does it affect your outcomes in COVID-19? So there have been a lot of studies done, large international multi-center studies have been done. And the common theme and the result among all of these studies was, if you have chronic liver disease or if you have cirrhosis, you will have a bad outcome with this COVID-19. So that's the main finding from all these studies, that having a cirrhosis will lead to more requirement of ventilator, more requirement of the ICU care, and ultimately the higher mortality in such cases as compared to somebody who does not have an underlying cirrhosis. Now, why does it happen in cirrhosis? This can be explained because cirrhosis have something called, these patients have cirrhosis associated immune dysfunction, which is because of reduced components of complement or reduced macrophage activation or impaired lymphocyte or neutrophil function or the toll-like receptor upregulation or the intestinal dysbiosis. These are all possible in COVID and cirrhosis patients and leading to the higher mortality in such patients. Now, I found it interesting that in the cirrhotic patients who have COVID-19, yes, their fatality rates are higher when they get COVID-19, but if they survive that acute illness phase, after that, they are back to their baseline. Their readmission or survival does not get affected by their prior COVID illness. Also, their cirrhosis does not progress any faster than what the cirrhosis will usually do. So COVID-19 does not affect the progression of cirrhosis. COVID-19, if you survive with cirrhosis, does not affect your survival after that. So that's something good to know for our patients who suffered with COVID-19 and had cirrhosis. Now, this is an interesting study. I found this diagram here on the left. If you see, there are patients who had chronic liver disease without having any cirrhosis. And then the last three categories are patient with cirrhosis and Child-Pugh class A, B, and C. And these are the mortality rates. If once the patient is hospitalized and has chronic liver disease, mortality is high, 8% as compared to 2.7, 2.5 with somebody who does not have any underlying disease. So 8% mortality becomes even higher in these patients when you have CPT class A, B, and C, and you can see the mortality rate increasing from 22, 39, and 54 after that. Once these patients are hospitalized to ICU, the mortality rate is 20% with chronic liver disease, and it goes up to 40% with child class A, 62% with child class B, and about 79% with child class C. And the similar numbers are there once you start receiving the invasive ventilation. And look at, if you have invasive ventilation and you are child class C, the mortality rate is 90%. So survival chances just 10% in such cases. So it's a very high mortality rate in these patients. Now, what do we understand from these statistics and what do we do for our patients? So it is important to recognize that this group of patients of cirrhosis and chronic liver disease is a vulnerable group. So if you have any concern of COVID-19, they should be sent for early testing. They should be admitted early rather than asked to manage at home because they have a high complication rate. Now, also, it's important to know that patients may have hepatic decompensation as the first sign of COVID without having any other sign. So there were 47% patients who had this hepatic decompensation as the first sign and later on had some other COVID symptoms. And 24% of these patients did not have any other kind of symptom. They just had this hepatic decompensation. So if the patient get admitted with worsening ascites or hepatic encephalopathy, it is important in such patients to rule out the COVID-19. And that's the important take point from these diseases. And again, the COVID-19 we know causes increased coagulopathy, and cirrhosis also does the same. So these patients are at increased risk of thrombosis. And now when they are at increased risk of thrombosis, the next thing which comes is, should we give thromboprophylaxis or not? And it was reassuring to see in a study, I think it was done in Italy, and they found that the 40 of their patients where they used thromboprophylaxis in the form of heparin, and there was no increased bleeding risk in these patients of cirrhosis. So that was something reassuring. Now, COVID-19 in liver transplant patients, it's not a high number of patients with COVID-19 and liver transplant, but this may be of interest to some of us who regularly see patients with liver transplant. And we may want to believe that if you have liver transplant, you are taking immunosuppressants, so you're bound to have a bad outcome. That's not the case. If you see the studies, there's a big series, the Spanish series and the multinational series, about 150 patients, they found 6% and 14% of patients were completely asymptomatic. And these are the patients, keep in mind that they are liver transplant and immunosuppressed with immunosuppressants going on every day. So they were completely asymptomatic. So it does not mean liver transplant and immunosuppression that you will have a bad outcome. That's not the case. And there was a difference in the symptom in the GI tract wise, that the diarrhea was noted much more commonly in the liver transplant patient as compared to somebody who does not have a liver transplant. And like I mentioned in the first point here on the slide, that having the transplant and COVID-19 does not mean that you will have a bad outcome. That's why the international guidelines do not recommend stopping the immunosuppression in a transplant patient if they get affected with COVID-19. That immunosuppression must go on unless you have a concern of superadded bacterial infection or worsening respiratory failure, then you can consider that. Now, going on to the pancreas involvement. Lately, the pancreas involvement is getting much more attention with COVID-19, and it's plausible that pancreas can get involved because pancreas, ductal cells, acinar cells, and islet cells, they all express ACE2 receptors. So it's possible that the COVID-19 can affect the pancreas. But the researchers largely believe associating COVID-19 to acute pancreatitis is too early right now, and there is no clear evidence of COVID-19 doing that, even though we have abundant studies showing lipase and amylase elevation. So how do we explain the lipase amylase elevation in such cases if it is not really the COVID-19 causing pancreatitis? So the reasons could be that amylase is elevated because it is coming from salivary glands, which can be affected, or is coming from the lungs, which is very commonly affected in COVID-19. Also, amylase lipase is not just about the secretion, it's also about how quickly they get excreted, and they are both excreted by the kidneys. If the kidney is affected by COVID-19, then you're going to have a much slower excretion. So that is also important to remember. Then there are confounders. Patients with diabetes, we know they are known to have a higher baseline of lipase amylase. Renal failure patients will have slower clearance, same with acidosis. So these patients have all these comorbid conditions, and that may be one of the reasons which can explain the amylase lipase elevation rather than just blaming it to pancreatitis from COVID-19 itself. Also, gastroenteritis is causes the non-specific elevation of lipase and amylase both. So that may be one of the reasons why these enzymes get elevated. Now, there were larger studies, a retrospective cohort. In the first one here mentioned is more than 11,000 patients, almost 12,000 patients there. And they noticed in these 12,000 COVID-19 patients, about 0.27% had pancreatitis. And the other study, about 63,000 patients, and the patients who had acute pancreatitis was about 0.07. This is a very low percentage of patients. If really COVID-19 has predilection to involve pancreas and causes pancreatitis, these numbers are very low. And we don't know whether these numbers, the low number of cases of pancreatitis in COVID-19, are they really COVID-19, or they are because of the usual risk factors like gallstone or alcohol, which do not cease to exist during the COVID-19. They are still there. And more so, we are not even doing the further testing, like we are not doing any CT scans, we're like not having the detailed history, maybe because of having the exposure risk. So it's not clear that COVID-19 having pancreatitis as really is COVID-19, or some other factors are possible here, the usual risk factors. There was the COVID PAN collaborative study where the researchers from all over the world collaborated, and they included about close to 1,800 patients of acute pancreatitis who had COVID-19 as well. And their findings were not surprising. Their findings were these patients had prolonged length of stay. They had persistent organ failure. They had higher 30-day mortality. But this is all expected in a patient of acute pancreatitis, whether you have COVID or you don't have COVID. That's going to happen with acute pancreatitis. So this study shows that pancreatitis in patients with COVID-19 will still have the bad outcome, which is anyway there. It does not prove that COVID-19 causes the pancreatitis. Now, coming to the next topic of my talk, long haul COVID, or we call it different names now, long haulers or long COVID or post-COVID symptoms or post-COVID syndrome. This means that persistence of a symptom or recurrence of a symptom 30 days after the initial onset. So if you have these symptoms after 30 days, like, or 4 or more weeks after, then you are labeled as having a long haul COVID. And it was very interesting to see that post-COVID symptom is also possible in patients who, to begin with, were asymptomatic with COVID-19. So we all know post-COVID, now we know that post-COVID is more common in patients who were symptomatic and hospitalized, but 20% of patients were asymptomatic and they have long haul symptoms. So I think these will be the real challenge cases if they miss that initial diagnosis and now come with vague symptoms, and we're doing expensive tests and we still don't know what is causing them, and that may be just the long haul COVID. Now, long haul COVID, as far as the GI tract is involved, we do not have the much symptoms involved from GI standpoint. One study reported that the GERD was common. The other study reported esophageal symptoms, same as GERD, dysphagia, or higher use of laxatives or antiemetics or histamine antagonists or antacids or antidiarrheals were used by many more patients, which is expected after diarrhea that patients will use the antidiarrheals. Now, this is a study which just came a couple of weeks ago, and a very interesting study which finally shows and proves that the cholangiocytes do have a higher expression of the receptors, the ACE receptors. So this study came from NYU, the New York University, and they found that 12 patients among all the liver patients which they evaluated during the COVID-19 pandemic, 12 patients had something called as bile duct injury, which they defined as people who had alkaline phosphatase elevated more than 3 times the upper limit of normal and also had abnormal MRCP. So most of these 12 patients were, out of these 12, 11 were men, and the mean age was 58. And the mean elevation of alkaline phosphatase was up to 1855 units per liter. That's a very high elevation level of alkaline phosphatase. MRCP, the common finding was intrahepatic duct bleeding. And the liver biopsy proved that these patients had cholangiopathy. 5 of these patients were referred for liver transplant, and one of them has actually got the liver transplant for post-COVID cholangiopathy. Now, moving on to the last few slides of COVID-19 and nutrition. Now, we all have seen the COVID-19 leads to the weight loss in these patients. And the first and foremost in these cases will be to assess that who is at risk for malnutrition. So this is the criteria these are criteria validated in the literature. And the first one is a must criteria where they have the BMI score of 0, 1, and 2. As you can see, more than 20 is scored 0 and less than 18.5 is score of 2. Similarly, the amount of weight you have lost in the last 3 to 6 months gives you a score of 0, 1, and 2. And if you are not able to eat for 5 days, or if there's a possibility that you will not be able to eat for 5 days, like you are on a ventilator, you're not going to be able to eat and enteral nutrition is not started, so that patient gets a score of 2. So ultimately you add up all these scores, and based on what is the total score, you get a risk rating. If you have a total score of 0, you have a low risk of malnutrition. A risk of score of 1 is a medium risk, and if you have a score of 2 or above is a high risk of malnutrition. Then we may not be able to get the height in all the patients. So there are alternative methods. You can use the ulnar length, there are charts you can corroborate from ulnar length to the height. And also BMI, we can calculate indirectly from the mid-arm circumference. Then there are other the criterias where the nutritional risk screening score is there, where similarly they see amount of weight loss more than 5% in 3 months or 2 months or 1 month, and how much is the reduced food intake is about 50% or 25% or less than 25%. Based on that, you get a score of 1, 2, and 3. And on the severity of disease, also they have mentioned some prototypes of disease, and that gives you a scoring. So if you are on in intensive care or ventilator, you automatically get a score of 3, and the total score decides whether you have a malnutrition risk or not. Then there's a Nutrix score, which involves all these criteria: age, Apache score, SOFA score, number of comorbidities, and days from hospital to ICU admission, and interleukin 6. This score is also flexible. If you do not have an interleukin 6 level available, you can still calculate from the remaining 5. And if interleukin 6 is available, then you can calculate the risk of malnutrition from these scores. And this is the recent scoring system which came, global leadership initiative on malnutrition. And here they have a phenotypic criteria as well as etiologic criteria. And you have to have one phenotypic criteria as well as one etiologic criteria to define that you have malnutrition. And the criteria are almost similar, that you have lost weight about 5% or 10%, and you have a low BMI in the Asian population, less than 18.5 for less than 70, or less than 20 BMI for more than 70, or you have reduced muscle mass. You just need one of these criteria. And the etiologic criteria, they are if you have a less than 50% of energy requirement for more than a week, or if you have a GI condition that will adversely impact your food assimilation, or a GI condition which will impact your absorption. So this is important to understand. A GI condition which will affect the food assimilation means like if you have a dysphagia or unable to eat, low appetite, dysgeusia, so that is affecting your intake. So that automatically gives you a score here that you have a positive etiologic criteria. And food absorption, of course, if you have a malabsorption, COVID-19 affecting your intestine, you may not be able to absorb well. So that's the absorption problem with COVID-19. Now, these are the recent recommendations for COVID-19 patients, which were given by the European Society of Parenteral and Enteral Nutrition. And they give about 27 kilocalorie per kg per body weight for a patient who has a multiple comorbid condition and age more than 65. And they recommend a similar number if you are an older patient. But if you are severely underweight and have multiple comorbid condition, the daily requirement should be 30 kilocalorie per kg per body weight. And similarly, protein requirement is 1. And if you have multiple conditions, you have more than 1, which can go up to actually 2 grams per kg body weight per day. Now, fat and carbohydrate ratio you given depends on whether you are on a ventilator support or not. If you're on a ventilator support, you need a higher fat content, about 50-50 ratio with carbohydrate. But if you're not requiring ventilator support, you can use 30% of fat and 70% of carbohydrate. Now, vitamins and minerals in general, a lot of them are known to provide good immune function because they are one of the cofactors in different several enzymatic reactions. But there is no clear data and clear evidence that these are required to protect you from COVID-19. So research does not suggest that you should start taking in the higher doses. They just recommend you should take in a daily recommended dose. And there's no need to overdo on these vitamins until more research shows up. Now, when the patient is affected with COVID-19, not able to eat orally, like any other disease who's critically ill, it is important to start oral feeds first. If the patient is not able to eat much, you should start giving them nutritional supplements. And it is important to give the nutritional supplement first, then the oral diet, because you want to give them energy dense food so that they can have high calorie intake from the oral route. If that is not possible, you will have enteral nutrition or parenteral nutrition if this is not possible. Now, the dietary supplements, there are a lot of them have been studied, and we heard a lot about them from different parts of the world: melatonin, omega-3 fatty acid, probiotics, vitamin C, D, and zinc. But overall, the research data is insufficient to suggest for them or against them. So we do not know, but a lot of them have actually research going on. So we will know soon about some of them, whether they are useful or not. And this is my last slide here. In the middle, you will see a picture which I took from the Canadian Society of Parenteral and Enteral Nutrition. This is for when we commonly get asked about that I was recently admitted with COVID-19, I have lost weight, what should I eat? So they recommend high protein diet. They also recommend eating whole grain foods. And they also say that you should make a diary of writing down that how much of your usual intake you are taking, so that you have some record that whether you are eating less or more. And if you're not able to eat 50% of what you were usually taking, you should consult a physician. There may be some other cause behind that, and you should have adequate fluid. Now, I've given some pictures here, broken down to our typical Indian diet, what we can recommend our patients. We have to first tell them to take energy dense food. And this is something in the north we'll call as khichdi. And I think it's in the southern parts we'll call as the rasam with rice, which is high calorie energy food, or you can have a curd rice. These are paranthas with butter, or you can have nuts with high calorie, or also we encourage taking more fruits and vegetables. The protein content can come for a vegetarian person from the paneer or the cheese which they eat, or the soy can give you protein. And people who can have the meat, they can have chicken or the egg or fish. These are all good sources of protein. And with this here, I will thank you all for giving me the opportunity, and I'll take any questions.
Yeah, it's open for questions. Ram, you want to start with? Your microphone is muted. Your microphone is muted, Ram.
Thank you, thank you. I have one that's been bothering me, and I have been reading in the recent past. If you look at all the cell systems, cell types that are directly affected by COVID, there seem to be not many of them. For example, in the nervous system, there's no evidence that direct neurons, oligodendrocytes, or microglia are involved. But there may be some action going on in the endothelial cell. Similarly, as you were mentioning, there is no great involvement of the cholangiocytes or hepatocytes. And with whatever biopsy data, autopsy data you have, is there evidence of action in the endothelial cells? What's going on? How could we have this degree of, for example, diarrhea without direct involvement of mucosal cells? What else is going on?
Well, the other factors which are like the different factors here possible, and I think this is the, like any GI tract infection, you can have a dysbiosis, and that's why patients going through one enteric disease and they may have diarrhea going on after that, because you have a dysbiome and there is no balance between the good bacteria and the bad bacteria. Then the second reason could be, which I think we're going to see a lot more patients of that after COVID, especially, that it may be the post-infectious IBS. But that's not something what you're asking me. What you're asking me, what other factors can cause it? It may be some medications they are taking, or like I also mentioned, that the COVID-19, which we don't know yet, that may be causing the activation of the enteric nervous system and hence stimulating the more secretion of these enzymes into the intestinal tract, which is giving the diarrhea. So you do not really have to have a direct invasion of the cells of the intestine by the COVID-19 to cause diarrhea.
So many ways this could happen, the symptoms, but there seems to be little evidence of a direct invasion of cells that belong to the GI tract. That's where
that's like a very little evidence. But also we have to be mindful. There's a study, like I have mentioned, that we cannot go by the ACE2 receptor expression, because we know now that TRMPSS, the protease enzyme that is required for internalization of COVID-19. So once the spike protein binds to ACE2, it will not lead to internalization of the COVID-19 into the cell. You need presence of this protease. And also there are other proteins you need for internalization of the virus. So maybe the other cells have less AT2, maybe have less ACE receptor, but they have overexpression of the other proteins, which will compensate for the lower presence of this ACE2 receptor.
Okay, thank you.
Sudhakar, you have any questions? You're muted.
Yeah, I have no questions. I have only a few compliments that so nicely that he has summarized all the evidence-based medicine to give a lot of take-home messages of the involvement of the GI tract, how it happens, so on and so forth. So nice of Dr. Jasbir. Maybe others have some questions.
Yeah,
thank you.
Anyone has a question, go ahead and ask while I'll take. So let me, the nutrition and the gut microbiome, let's talk about that a little bit, if you may. I think there's more recent data suggesting that patients whose gut microbiome is completely altered because of COVID tend to have adverse outcomes, tend to have more likely to have severe ARDS and more likely to actually die. So which begs the question, one is what's actually altering the gut microbiome? Number one, The gut microbiome being the most important immune modulator. Other than the immune system, the gut is the second most important immune system, as we all know. And so if this disease is all about immune cytokines causing lung damage, brain damage, heart damage, and gut must have been playing a very important role, right? I mean, we can't argue against that. So what is altering it? Number one, there are many possibilities, and I want you to comment on it. One is that we often use antibacterials early in the case in managing COVID. Everybody gets azithromycin or some other antibiotic. Number one, is that really helping or harming the gut microbiome? Because early in the day, even though there's no evidence antibacterial are helpful, almost everybody gets them. And the disease is very mild in the first week. It actually gets worse in the second week. And are these antibiotics altering the microbiome and making things worse for us? The second thing is a year of lockdown. Obviously, we are not exercising the same way. We are not eating the same way. That itself, the lockdown itself, without even getting infected, may have altered gut microbiome. And the last part that I want you to comment on is you have published on metabolic syndromes and its effects on COVID and otherwise pre-diabetes, diabetes, and all that. So as India prepares for the next wave, if at all, we hope it won't happen, but we're already seeing some of it in Maharashtra and Kerala. So I wouldn't be surprised if we at least see a mini wave. Would you advocate people to alter their diets so they are, less likely to get metabolic syndrome? So do something about it rather than eat whatever they like. I mean, you actually in your last slide even put carbs, which is I'm surprised that you said eat paratha with butter. But is that what you want to eat if you think that negatively affects outcomes in COVID patients? So go ahead and comment as much as you can.
Yeah, right. So Dr. Smith, these are all good comments. So I'll start with my last slide comment first. I want to clarify one thing here, why I mentioned those paranthas and high dense food. Those are the foods only for people who have lost excessive weight. And if you know from one of our colleagues who have seen us for this post-COVID symptom and excessive weight loss, is for patients who have lost weight way higher than expected and they want to regain the weight. That's where you want to have them energy dense food, or you want to have, they recommend, these are the guidelines suggesting that if you cannot eat 50% of the diet, you should start replacing them with some kind of shakes and juices and some kind of smoothies to get calorie dense. And this is not like forever. Once you gain back your weight, it is always recommended that you have to go back to the healthy diet, which has been shown previously, even before COVID, that if you have more fruits and vegetables intake, it of course maintains a healthy gut microbiome, which if affected, and you mentioned that this is the first line of defense, the adaptive immunity, and will affect all over the body if you do not have a healthy microbiome there. I'm not sure that how much of we are clear on this fact, but we cannot ignore this fact that the gut microbiome, which has been proven to be like implicating in a lot of other diseases, may be an important factor in COVID-19. So it's important to just consume the healthy diet. You cannot go on with this high carb and energy rich foods, especially if you have not lost weight. And going without the exercise or eating unhealthy for a long time, again, will have the same kind of effect. So I think the pandemic and the lockdowns have introduced that kind of diet patterns and the lifestyles in the patients, which is difficult for some of us to do, but we got to do best what we can do. And it is important to eat healthy at the end if we have to have some better chance against this third wave if it happens. Now, coming on to the last point, which you mentioned about the metabolic syndrome. Now, metabolic and the diabetes and people who have fatty liver, there was also much research talked about having fatty liver. Does it have some detrimental effect when you get COVID-19? There are like two large databases. One is what the international registry and the other one was from US. And they found that having NAFLD, after you have controlled for obesity, just having NAFLD does not give you adverse risk of like some bad outcomes with COVID-19. But having said that, we also have to be mindful that a person who's going to have NAFLD will have other metabolic factors like diabetes, obesity, and hypertension, which are well known now to be bad risk factors, and you're going to have a bad outcome if you have one of these. So having a bad kind of lifestyle, eating unhealthy, not having enough exercise, and ultimately ending up with metabolic syndrome is a bad thing. NAFLD per se is not bad. Now, the diabetes we recently published, and you guided me on that study. We found interesting results that we know now that age is the number one factor which affects the mortality in the COVID-19. What we found, if you stratify these patients who are diabetic, and if you stratify them based on their age, older defined as more than 55 age or younger less than 55 age, in the patients who were older than 55, their diabetes status did not affect their mortality above their age. So whatever effect of mortality had on their mortality was because of their age. It was not because of their diabetes. But in the younger population who have diabetes, they have a much detrimental effect because of their diabetes. So it's important to explain to our younger patients who have diabetes that in your case, even though you are not old, yes, the age is on your side, which was at least initially in the first part of the pandemic when the older were affected more, that it's not that if you are younger and you have diabetes, nothing can happen. Having young age with diabetes was a problem in the study which we saw. And again, we also noticed, which has been shown several times by other researchers, that if you have hyperglycemia at the time of COVID admission, regardless of your diabetes state, whether you're diabetic or normoglycemic or you are having a pre-diabetes, having a hyperglycemia at the time of admission is going to have a bad outcome, more likelihood to have a bad outcome with COVID-19. So it's important to maintain a lifestyle where you do not end up with these metabolic syndromes. And lastly, I will comment on pre-diabetes. There are not much studies on the pre-diabetes. We saw that the pre-diabetes does not really affect your outcome with 19 as does the diabetes, which we may believe that because pre-diabetes and diabetes, they almost have the similar metabolic derangement. It's just that pre-diabetes has a little bit less. But pre-diabetes does not really affect the mortality, but it has to be shown in the other larger studies. Lakshmi, I cannot hear you.
Yeah, I can hear you now.
Yes.
Perfect. Ram, any other questions before I can? The audience can ask any questions if they have.
I had asked Dr. Buddharaju if he was available, but I don't think he logged in.
Okay.
I was just reading today about the study from the UK, where there was a mention, which was surprising to me, that in the long COVID UK study, 27% of people who recovered are deemed to be unable to function independently. 50% have damage to lungs, heart, and kidney. No mention of the GI tract, which was puzzling to me. So if it is an indirect injury, there should be enough trouble with the gut and liver. So I'm still perplexed as to what actually happens to the GI tract, gut mucosa, and liver. They are lucky, but it's puzzling as to how this disease works. And at the same time, we all should be very, very alert to this multi-system long COVID involvement, starting with Dr. Makkar today. We'll pay attention to the other systems in the immediate few weeks.
Yeah, I think we do see post-COVID syndromes involving the GI tract. And I think he and I managed one of them. So there are a variety of them. Chronic diarrhea is one. Weight loss that persists. When you have the acute syndrome, many people lose substantial amount of weight. But if there are some whose weight remains, they lose weight and they don't gain it back. They may be eating and not gain it back. The third group who complain of this GERD-like symptoms and bloating. And so we do see that. But you also have to understand they're quite anxious. There are a lot of cognitive changes that also happen. So if we don't know, as I think Jasveer mentioned, how much of it is post-infectious irritable bowel syndrome that they're developing, that's still unknown. More recent data is showing that substantial number of patients who have COVID activate the EB virus. Almost all of us have been infected with EB virus, but it hardly does anything to us. But after COVID, it's some number of patients who've been studied, the EB virus gets reactivated. Whether that reactivation leads to any kind of syndrome is unknown. But at least that's a surprise that we're suddenly seeing this, which we didn't consider studying it in the past. So we now, as we're going forward with this current group of patients, we've been looking to see the EB virus status. Is there activation? Are we seeing IgM titers come up again? And what is this interplay between COVID and EB virus? We don't know it, but we're suddenly seeing this activation. I think somebody has a question. Go ahead on the chat window. I see you want to ask a question and an update. Please go ahead.
Sir, hello everyone, sir. Thank you for the opportunity. I have an update and a question, sir. First is the good news is for all Indians is US made Johnson & Johnson vaccine has been only cleared last night by Drug Control General of India, sir. This becomes the fourth available vaccine to all Indians, all eligible Indians, sir, after Covishield, Covaxin, Sputnik V, and this is the fourth vaccine, sir. As we are all aware, this is a single dose vaccine. This is also adenovirus replication incapable virus, sir, single dose virus. As we are all aware, it was held for a while due to that blood clots, rare blood clots adverse events. Now it was given emergency use authorization with clearly mentioning this rare side effects, sir, and the thrombocytopenia side effect, predominantly in the 18 years and over, sir. And one more good news to all the promoters, supporters of third or a booster dose, sir. At least three major European countries, UK, Germany, France, I think, sir, along with CDC, USA, are now promoting for the third dose, sir. Most probably it'll be getting a clearance, third or a booster dose, sir. And Ministry of Health, that is the second update on the booster, but still the WHO protests, sir, against the third or a booster dose. And another important news is we all thank US for sharing at least 100 million doses to Africa, sir. That is one more very, very charity or philanthropy, sir, on the request of the World Trade Organization and WHO. That is a wonderful thing, sir. Thank all the Americans, sir, US. And Ministry of Health and Family Welfare, Government of India has given a revised Ministry of Health and Family Welfare, Government of India has given a revised admission and discharge policy guidelines in view of probable third wave, sir. Hope, pray God, it will not be a third wave. But still, the government has given guidelines. Important among those admission criteria, it's reiterating, sir, not to deny admission to any COVID suspect just with the pretext they don't have a COVID positive report, sir. COVID positive RT-PCR report. This was given last time also, sir, and they're reiterating that same admission criteria, sir. And update is over, sir. One more question to the speaker, sir. Sir, all along over the last 1.5 years, we have given instruction to all the patients and all the COVID patients, sir, that they use the toilet, washroom, sir. While after completion, it should be flushed with closed lid only. That is, of course, it's a general manners also, sir. Flushing the toilet with the closed lid, it's a general manners also. But in the COVID, we have given special instructions with the to use the washroom like this, sir. With the probable at that time knowledge, sir, first wave knowledge, the GA passage is there. Probable infecting virus. Now the speaker sir has elegantly said it is most probably not infective capacity virus shedding. Thanks for that updated news, sir. Maybe not the fecal-oral route transmission, sir. This faces and with that flushing of the toilet with an open lid, it might generate aerosols and might produce the regular route of infections, sir, like transnasal or transoral, like that spreads are not that fecal-oral spread, sir. That time it was the new information, sir. I'm not aware of the present. And still we are practicing flushing the toilet with even after 1.5 years with a closed lid only. Of course, that is the general manners only also, sir. Thank you, Chilmuri sir, Kairam sir, and Principal sir for allowing me.
Yeah.
So
you want to comment about it, Jaspreet?
Yes, I would like. So I want to clarify something about this fecal-oral route. We do not have enough evidence to definitely prove that the fecal-oral transmission is there by this virus, but still all the data is pointing towards that. So I would be still careful, and I will still tell the patients that they should practice this, because having a lack of study at this point does not mean that the fecal-oral transmission does not exist, when we know that it existed with the other similar viruses in the past. And we have both kind of evidence that the virus is present, but maybe live, may not be live. If live, it is not infectious. We don't know what research will come forth, but I think it will not be a bad advice to be overcautious still at this point.
I'm also not saying about the fecal-oral, sir, that the regular route of transmission of COVID, sir, the transnational from this aerosols, sir, that are generated with flushing the toilet with the lid open. Of course, it is the general manner, sir, to keep the flush the toilet with the lids closed. But we have given special instruction to all the patients to flush their toilets with the lids closed, and not anyone to use the toilet at least for half an hour after the COVID patient use, if they don't have a separate washroom, sir. That was what the instruction we are giving all along, sir.
Yeah.
Right.
Aerosol, via aerosol, sir. Via aerosol, I'm saying, sir.
No, that I think it's a theoretical possibility, but there is no
okay, sir.
there is no experimental evidence currently suggesting that flushing the toilet will aerosolize it for us to get infected. I think that is not. It could happen theoretically, but I don't think that is known. And your comments about the update of Janssen or Johnson & Johnson vaccine, we've used it in the US. It's quite an effective vaccine. Initially, we were concerned whether it's as good as the mRNA vaccines, but the data that came out this week shows that it is at least as good as mRNA vaccines. They are in some parts of United States.
See that microphone. Microphone.
As good as, no, I think the internet connection. Can you hear me or no?
Now,
yes,
yes.
sir.
You can hear me?
Yes,
Yes,
now.
sir.
Yeah. So my point is that they're as good as mRNA vaccines. There were some concerns they were not that effective against Delta, but more recent data shows that they're at least as good as mRNA vaccines. And I think they have the advantage of taking only one shot, and the temperature control also is relatively easy to maintain with them. So I think if India has it, that's one additional opportunity to give people vaccines. Yeah. Is the virus shed through fecal route not infective and can't cause even aerosol spread as suggested by the previous gentleman? Just be it's the same question.
Yeah, I think the virus is there. The virus is there. We just don't have the evidence whether this virus is able to be transmitted fecal-orally or not. So I think it's not a bad idea to keep telling our patients to be cautious about this fecal transmission. And aerosolization, like you said, it's theoretically possible. We just don't know. We don't have any evidence in the studies yet for that.
Yeah, I think the transmission is still the cough and upper airway transmission into the air, and that is still thought to be the predominant way of how the virus spreads, almost like chickenpox. That's how it's considered to be. Yeah. Any other questions?
Chilmuru sir, comment about the third or booster dose, sir, across Europe and US.
So in the United States, it's still the CDC is considering. It's not yet offered yet. And in the United States, the CDC is saying at current time only to give it to people who are immunosuppressed or immunocompromised one way or the other, either HIV or on immunosuppressive drugs like chemotherapy, or people who had organ transplants, or any reason why their immune system is not normal. That's the group they want us to give booster doses. That's number one. But we haven't started yet. The FDA has to clear it. The second thing is which vaccine to actually give as a booster. Would you give the same? Let's say you got Pfizer, 2 doses. Would you give another dose of Pfizer, or do you switch to another type of vaccine? That's not clear because obviously the adjuvants are different for different vaccines. So should you take something different? I think that's an easier question to answer in India. I think if you take in 2 doses of AstraZeneca, it would be reasonable to do an mRNA booster in India. But in the United States, majority of us got mRNA as our primary vaccine. What should we take as a booster is unclear. What I think the future probably in winter would be a modified mRNA vaccine would become available, and that would be a better option to take a booster.
Yes, sir. Yes.
Yeah, so we don't know when. I think United States will see booster doses in September. I think September.
And that's what they're saying. But UK is promoting for
probably
healthcare
will
workers.
tell us, and probably will be the same vaccine, another dose. That's so. If I got 2 doses of Pfizer, most likely they'll tell me to take another dose of Pfizer. That's what I think initially what they're going to say, because that's what the Israelis did. That's where the data is. And so they will go with the data for now. And hopefully as more information becomes available, because there are questions about what should you do with somebody who had only 1 dose of vaccine, which is Johnson & Johnson. So they got 1 dose. What do you boost with? Because Johnson & Johnson is not recommending people take a booster dose of their vaccine. So I think that's still an unanswered question, what to do with depending on what vaccine was your primary series of doses that you got. And it's also unclear what you and I as healthcare workers, are we, do we deserve a dose, or do we have to demonstrate that we have immunosuppression before we get? That's also not clear.
But UK is promoting for healthcare workers only, sir. 3rd dose, booster dose. UK, sir.
UK, yes, but not the United States. The CDC is not saying that for healthcare workers. Yes. It's quite likely they might recommend for healthcare workers. I think the big thing that change that will come to United States will be Pfizer is most likely going to get their full FDA approval by September. Once the vaccine is not EUA and fully authorized, then anyone can take vaccine anytime they like. No one can restrict them as long as they're being reasonable. 3rd dose, anyone can go to the doctor and they can order it and take it. So there won't be any restrictions at that time. So that also will change everything in the United States.
Okay, sir. Okay.
So what could be the most probable mechanism of infection in neonates and babies less than 6 months with immature GI tracts? Jasbir, you want to answer that?
Well, I think the fecal-oral transmission or the respiratory tract, staying close to the family members who have the respiratory disease, they are getting infected mainly through the respiratory tract. Fecal-oral transmission is still not proven, so I would still stick to the transmission through the respiratory secretions.
Yeah. That's our belief too, that I think that's predominantly how a neonate would get it. It's still respiratory route, I think. There's no evidence other routes are playing a role in neonates at this point. It behaves almost exactly like in adults. I don't think it is any different.
Jaspir, you had made comments early on about the microbiome and the dysbiosis that occurs, especially if it's related to the antibiotic use. In India, there was a lot of antibiotic use in April and May. What did you see regarding fungal infection in such altered gut?
Well, I think that is regardless of COVID or not COVID. If you have a lot of antibiotics being used, you are prone to get a fungal infection after that because of dysbiosis. And but I'm not sure whether we can explain just that. And I don't think there is evidence in India as well that what explains why in India people got so many of cases of mucormycosis and aspergillosis, these cases. But at that time, I was looking up the studies done in the previous times in US, and there were a lot of interesting studies I came across. Of course, these are larger studies where the patients sometimes after like a hurricane or a tsunami came, or the tongue depressors which came from a company which were infected. So these kind of sources, like there is something else other than just the antibiotic, which was causing so many, because people blamed it to steroids. Steroids have been used for such a long time. It cannot be the only factor causing mucormycosis so common in India. There was something else which we just don't understand yet. And now similarly, on the same pattern, I came across news in Delhi. Gangaram Hospital reported that 14 of their patients from last month reported multiple liver abscesses in these patients. And again, this you can probably blame onto the steroids, the patients who were having immune system suppressed for COVID-19 or were suppressed because of the steroids, or we know entamoeba is endemic in India. And when the patients come with abdominal pain and diarrhea, and everybody thinks it is COVID, and we missed that diagnosis to begin with. And then we started the steroids and their immunity is further lowered. So you got multiple abscesses and large abscesses. So that's another, like a new pattern, what I have noticed recently.
Dr.
So,
Sudhakar, Dr. Sudhakar,
United States, just a comment on the bacterial emergence. So in the year
Your microphone, Sridhar. You're not audible, Sridhar.
Okay, can you hear me now?
Yes, we can hear you.
Yeah. So in terms of bacterial resistance, so this year we're seeing a dramatic increase in carbancillin-resistant enterococci infections throughout hospitals in the United States. We have seen an increase in Candida auris infections across the United States. So that's because of all the antibiotics we used last year, and we used extensively, even though they were never shown to be effective, and we are paying the cost of it in the United States. I think this is happening in Europe too. So as we prepare for the next wave, we need to be cognizant about why we're using antibiotics and how long we want to, because they clearly have a very limited role in COVID, but I think there's some nervousness not to give anything to patients. So we end up giving some antibiotics, and they've always not been beneficial to patients. Yes, Sudhakar.
Yeah. Thank you very much. Shall we wind up the session?
Sure.
One last question.
Yeah.
Sudhakar, this one is for you. When the disease was very frequent, you had a lot of mucormycosis. What happened now? Zero or a few?
We are getting one every alternate day, approximately. We had about 350 cases in Visakhapatnam. And nowadays, we are getting about a case on every alternate day. We used to have about 10 cases in the beginning to start with every day. And that's how it is. It has come down significantly. With the number of cases coming down, the mucormycosis cases also have come down.
All right, thank you.
So there's one thing I want to mention as a general rule for COVID. We know very little about this disease, even now, as it relates to pathophysiology. And I think we all should have an open mind about everything we think about COVID, because it will change. Because although what we have is mostly observational evidence, when you go down to pathophysiology, we know very, very little about it. Dr. Kairam earlier mentioned that the mechanism of injury in the CNS is unknown. Likewise, ARDS, which is so common in COVID, we really don't know what causes ARDS. So typically, the alveolar site type 2 one is where you would see the origin of ARDS. In COVID, in all autopsies and all wherever biopsies were obtained, no one could find RNA, the COVID RNA in the alveolar site. So likewise, we can find a single abnormal cell in the GI tract that can explain the diarrhea that they get, or even the abnormal LFTs. So I think it's still pretty much an unknown disease. We have some ideas of what it is, but we really don't know enough. I think so. We keep an open mind and keep learning as we go is the best way to approach it. I think one last question, Jasbir, do you recommend probiotics, and how long would you give them?
I think the probiotics for the disease itself, there is no role. There's no evidence yet. But I'm thinking for the post-infectious, like the post-COVID diarrhea, if it's not resolving, I would give it a try, because we're not going to lose anything by trying the probiotic in a patient who's suffering with diarrhea after COVID, unless you have ruled out other causes like pancreas and other common etiologies, and it's not just something else.
Okay. Okay, Sudhakar, we're done. Do you want to close it? Or?
Yeah, we'll close it
I
for
have
now.
a last
And
question.
Somebody has a
go
question.
ahead. Yeah, please go ahead.
Last question, if I may.
Yeah, go ahead.
Please go ahead.
I wanted to ask if also in future if there is a scope for oral COVID vaccine. So what is the opportunity of herd immunity, like the oral polio vaccine that we have seen previously?
Number one, whether there is a oral vaccine in development, you mean?
Yes, actually, I have just come across something mentioned in Israel where they are coming up with an oral COVID vaccine. There are trials going on. So I just wanted to ask you about that.
There are a number of vaccines that are still being tried. There's a nasal spray that's being tried. I don't know about this oral vaccine. I'm sure that if we want to end the pandemic and treat 8 billion people, we have to develop a lot more easier ways of vaccinating people, whether it's oral or otherwise. It's not inconceivable to do oral because of the nature of the virus and how you deliver spike proteins to people. So I think they're not going to be available this year, I think, because they still have to go a lot of trials, but it's not inconceivable.
Indian-made Bharat Biotech is going for nasal vaccine, sir, Covaxin.
Yeah,
trials are very much on, sir. Very much on.
Yeah.
Okay. Thank you. Thank you, Dr. Chinmay.
Yeah. Okay, Sudhakar.
Yeah. Thank you very much. Thank you, Dr. Jasbir Makkad, for such an explicit presentation and taking the evidence into account. And all the discussion that went after that was also very lively. And I'm very much thankful to you for chipping in and sharing your thoughts. And thank you, Dr. Ram Mohan, for bringing in Dr. Makkad as well as Dr. Sridhar Chilumuri for accepting to moderate this particular session. So nice of you, all of you. And for the next 3-4 weeks, we have the speakers online, and I'll be discussing with Dr. Ram Mohan and coming out with who would be the next speaker the next week. Next week is the 15th of August, but still we will have our session as usual, though it's a public holiday over here. we'll have our session without losing the continuity. And I thank you all, whoever have joined this morning, and particularly Dr. Jasbir Makkar. Thank you very much. Bye-bye. And yeah.
He's not Kairam's man, he's Chilimuri's man.
I know. But you took a lot of trouble in inviting him and for spotting him.
Thank you, Jasbir. Thank you very much.
Thank you,
Very nice.
Dr. Kairam and Dr. Chilimuri. Thank you.
Yeah.
Thank you very much. Thank you.
Yeah.
Bye-bye.
Bye-bye. Bye-bye. Bye.
Bye-bye.